Assalamu alaikum, dear students. I am Dr. Ruqaya from the Department of Community Medicine, and today I will be discussing about an acute bacterial disease known as diphtheria. By the end of this presentation, the students must be able to answer what is diphtheria, what it is prevalence globally and in India, what are the different epidemiological determinants, what are the steps important for the control of diphtheria, and what is the immunization which is used for the prevention of diphtheria. This diphtheria is an acute bacterial infectious disease which is caused by toxogenic strains of Corynebacterium diphtheriae. Three major clinical types has been described as anterior nasal, facial, and laryngeal. Skin, conjunctiva, vulva, and other parts may also be affected. These bacilli multiply locally and produce powerful exotoxins. These exotoxins are responsible for the formation of grayish or yellowish membrane, commonly over the tonsils, pharynx, or larynx. And this membrane cannot be wiped away. This exotoxin may also cause marked congestion, edema, or local tissue destruction, along with enlargement of the regional lymph nodes and signs and symptoms of toxemia. This diphtheria word has been derived from a Greek word diptera, which means leather, owing to the formation of this pseudomembrane or false membrane. It was named in 1826 by the French physician Perry Bertini, and in the past the disease was called as a general disease or killer disease because there was no treatment. Fatality rate is about 10% in untreated cases, and in children under 5 years of age, 1 out of 5 children dies who gets diphtheria. Coming to the problem statement. Globally, this is a rare disease in most developed countries owing to routine children vaccination. In countries where satisfactory vaccination schemes have been instituted, the disease has so declined that it is no longer regarded as a public health problem. In developing countries, the disease continues to be endemic due to lack of adequate widespread immunization. The true numbers of diphtheria cases and deaths are unknown because of incomplete reporting from the most developing countries where the disease occurs. During 2019, 22,625 cases were reported globally, and this has been published by the WHO. This is a picture which has been published by the WHO on 23rd of July 2020, and it shows the diphtheria global annual reported cases and DTP third coverage from 1980 to 2019. The bars which are due to blue color shows the prevalence of number of cases, and the lines show the coverage of vaccine. In 2019, 22,625 cases of diphtheria were reported globally. Coming to the Indian scenario, diphtheria is an endemic disease. The available retrospective data indicates a declining trend of diphtheria due to the increasing coverage of immunization in children. The reported incidence during the year of 2017 was 5,293 cases and 148 deaths with a case fatality rate of about 2.79. This is a chart which shows the diphtheria cases in India, which has been published by the WHO Vaccine Preventable Disease Monitoring System 2019, and it shows the number of cases reported in India from 2010 to 2018. Coming to the epidemiological determinants of the disease. First, the agent. The agent, as I earlier said, is the Corynebacterium diphtheria. It's a gram-positive non-motile organism. It has no invasive power but produces powerful exotoxin after it multiplies locally at the place of invasion. This exotoxin is responsible for the formation of false membrane, marked congestion, and the enlargement of regional lymph nodes. The bacteria is sensitive to penicillin and is readily killed by heat and chemical agents. This is the picture which shows the Corynebacterium diphtheria. What are the sources of infection? The sources of infection can be cases which range from subclinical to frank clinical cases, or these may be mild or silent infections which may exhibit no more than a mere running nose or sore throat. And their source of infection can be carriers as well. They are estimated that 95 carriers for 5 clinical cases. These may be temporary or chronic, nasal or throat carriers. But the chronic carrier state may persist for a year or so unless the patient is treated. And what is the infective material? These include nasopharyngeal secretions, discharges from skin lesions, contaminated fomites, and possibly infected dusts. Period of infectivity ranges from 14 to 28 days from the onset of the disease, but carriers may remain infective for much longer periods. A case or carrier may be considered non-communicable when at least two cultures obtained from nose and throat 24 hours apart are negative for the diphtheria bacilli. What are the host factors? First of all, age. It usually affects children aged 1 to 5 years. And where widespread immunization is practiced, a shift in age incidence has been observed from preschool to school age. And coming to the gender, it affects both females and males equally. Immunity. Infants born of immune mothers are immune during the first few weeks or months of life. Before artificial immunization was given, large proportion of population in developing countries were acquiring active immunity through inapparent infections, which resulted in widespread production of antitoxin in the population. Coming to the environmental factors, these occur in all seasons, but winter months are more favorable. What are the modes of transmission? The disease is usually spread by the droplet infection. It may also be transmitted directly to susceptible persons from infected cutaneous lesions, and it may also be seen by nasopharyngeal secretions. Portal of entry. Common is the respiratory route, and from the non-respiratory route also may happen like from uh, cutaneous lesions like cuts, wounds, and ulcers, and through it may also occur through eye, genitalia, or middle ear. Coming to the incubation period, it may be from range from 2 to 6 days and occasionally longer. Coming to the clinical features of diphtheria. Respiratory tract forms of diphtheria consists of four types: pharyngotonsillar, laryngotracheal, or nasal, or combination of all these three. And then we have another form, that is the cutaneous form of diphtheria. Coming to the pharyngotonsillar diphtheria, the patient may have sore throat, difficulty in swallowing, and low grade fever at presentation. The examination of throat may show mild erythema, localized exudate, or pseudomembrane over tonsils. This membrane may be localized, or there may be a patch of this posterior pharynx on tonsil, or may cover the entire tonsil. And there may be edema in submandibular region, which can give rise to the characteristic bull neck appearance. This is the photograph which shows the presence of pseudomembrane over the tonsil, and it may seen extending into the backside towards the pharynx. And this is the photograph of showing the bull neck appearance, and this may be due to the edema in the submandibular region. Coming to the laryngotracheal diphtheria, it is usually preceded by pharyngotonsillar disease and is associated with fever, hoarseness, and croupy cough at presentation. And initially, it may be clinically indistinguishable from viral croup or epiglottis. Dyspnea may soon follow because of the obstruction caused by the membrane. This obstruction may even cause suffocation if not promptly relieved by intubation or tracheostomy. Nasal diphtheria is the mildest form of respiratory diphtheria, and it is usually localized in the septum or turbinates of one side of the nose, and the membrane may extend into the pharynx. This is the picture which shows the presence of the pseudomembrane in the right nostril of the child. Coming to the cutaneous diphtheria, it's most common in tropical areas and it may be due to secondary infection of previous skin abrasions or infection, and the presenting lesion, which is usually an ulcer, may be surrounded by an erythema and may be covered with membrane. This is the picture showing the cutaneous diphtheria. Coming to the control of diphtheria. First is the control in case of cases and carriers. It can be done by two ways. First is the early detection and isolation. Early detection will start from active search of cases immediately from the family or school contacts of the infected children. Swabs should be taken from both the nose and throat and examined by culture methods for diphtheria bacilli, and tests should be made for the virulence of the organism. Carriers can also be detected by cultural methods. In case of isolation, all cases or suspected cases or carriers should be isolated, preferably in a hospital for at least 14 days or until proved free of infection. And how are they going to be proved free of infection? That is by at least two consecutive nose and throat swabs taken 24 hours apart should be negative before terminating isolation. The treatment in case of cases should be given without any delay, and it is given in form of diphtheria antitoxin, which should be given either intramuscular or intravenous depending upon the severity of the disease, and the dose may range from 20,000 units to 1 lakh units depending upon the severity of the disease. For mild early pharyngeal or laryngeal cases, 20,000 to 40,000 units are required. For moderate nasopharyngeal disease, 40,000 to 60,000 units are required, and for severe extensive or late disease, 80,000 to 1 lakh units are required. And in addition to the antitoxin, each case should be treated with penicillin or erythromycin for 5 to 6 days to clear the throat. And in case of carriers, the treatment should be with erythromycin for 10 days orally, and the drug should be given orally. Coming to the control of diphtheria in contacts. These contacts should be given special attention. They should be throat swabbed and their immunity status should be determined. Now, there are different situations which pose different options. For example, if the primary immunization or booster dose by the contact was received within the previous 2 years, we need know nothing for the contact. When the primary course or booster dose of diphtheria toxide was received more than 2 years before, only a booster dose of diphtheria toxide need to be given. In case of non-immunized contacts, they should receive prophylactically penicillin as well as erythromycin, and they should be also given 1,000 to 2,000 units of diphtheria antitoxin, and they should be actively immunized against diphtheria. These contacts should be placed under medical surveillance and examined daily, and their bacteriological surveillance should be continued for several weeks by repeatedly swabbing them after weekly intervals. For the control of diphtheria in community, the only effective control is by active immunization with diphtheria toxide of all infants as early in life as possible, as scheduled, and with subsequent booster doses every 10 years thereafter. The aim should be to immunize before the infant loses his maternally derived immunity so that there will be a continuous protection from birth without any gap in immunity to natural disease. And therefore, it's important that the immunization levels should be high and the non immunized individuals are protected by this level of immunization. Now, coming to the final part, that is the diphtheria immunization. Currently, we have three types of vaccines for available for diphtheria. First is the combined vaccines like DPT, diphtheria pertussis tetanus vaccine, DTPW, that is diphtheria tetanus whole cell pertussis, DTPA, that is diphtheria tetanus acellular pertussis, DT, that is diphtheria tetanus toxide, small dt, that is diphtheria tetanus adult type, pentavalent, that is diphtheria, tetanus, pertussis, hepatitis B, and Hib vaccine. Then we have the single vaccines, which include formal toxide or alum precipitated toxide or purified toxide aluminum phosphate or purified toxide aluminum hydroxide or toxide antitoxin flocculus and antisera, which are the diphtheria antitoxins. Coming to the combined vaccines, the most preferred vaccine for the immunization of infants is the DPT vaccine. Firstly, because the infant can be immunized simultaneously for three disease, and also the pertussis component in DPT vaccine enhances the potency of the diphtheria toxide. It's of two types, plain and adsorbed. Adsorption is usually carried out on a mineral carrier like aluminum phosphate or hydroxide. Studies have shown that adsorption increases the immunological effectiveness of the vaccine. The WHO recommends that only adjuvant DPT preparations be utilized in immunization programs. The vaccine should not be frozen, it's freeze sensitive, and it should be stored in the ILR between 2 to 8 degrees Celsius. The optimal age is uh, as early as 6 weeks after birth, and require three doses each of zero point 0.5 ml, and it should be injected intramuscular. And the interval between doses is 4 weeks between the three doses, with a booster injection at 1.5 year to 2 years, and followed by another booster at the age of 5 to 6 years. Mode of administration is intramuscularly. There may be minor AFIs like fever and mild local reactions, which are very common in children. And the most severe complications may include neurological, like encephalopathy, prolonged convulsions, infantile spasms, and Ree's syndrome. And coming to the contraindications, minor illnesses are not considered contraindications, but DPT should not be repeated if a severe reaction has occurred in a previously given dose, or the child is seriously ill that he cannot be vaccinated. Otherwise, there are no further contraindications to it. And uh, since the vaccine is important, it should be given. Second, pentavalent vaccine, which is a form of combined vaccine. It provides protection to the child from five life threatening diseases, which include diphtheria, pertussis, tetanus, hepatitis B, and Haemophilus influenza type B. And giving pentavalent vaccine gives the advantage that we are giving uh, vaccine for five disease through one single prick, and it should be scheduled at 6, 10, and 14 weeks in the immunization program, except that the birth dose of hepatitis B and booster doses of DPT are continued. The pentavalent vaccine, which is used in the universal immunization program for India, is comes in a liquid form, and it is dose is 0.5 ml intramuscularly. It is also a free sensitive vaccine. Local AFIs occur like in form of pain, redness, and swelling. Fever may also occur. Vomiting and abnormal crying may also occur in the child. There are single vaccines. These are less frequently used. They are good immunizing agents, but because it's prone to give rise to serious reactions, therefore they are not used frequently. Each dose of these antigens generally contains 25 Loeffler units of diphtheria toxide. Coming to the antisera, they are mainstay of passive prophylaxis and also for treatment of diphtheria, and they are produced in horse serum. This is the graph which is published by WHO on 12th August 2020, and it shows us the immunization coverage with third dose of DTP containing vaccines from 1985 till 2019, and you may see different colors being used, which shows the percentage of the immunization coverage in different regions across the world, and different colors which depict the different percentage, like red depicts less than 50% coverage, pinkish color denotes 50 to 79%, light blue denotes 80 to 89%, and uh, dark blue shows more than 90%, and white and gray shows not data is not available. You can see with timing changing times, India is also showing increase in the coverage, and in 2018 to 2019 the coverage has been up to 90%. Diphtheria is deadly and immunization is the only safeguard. Thank you.